First of all, I just want to say welcome. So nice to see everybody here today. And I want to just, before we even do one more thing, introduce Roseanne McGrath. She is here. She's often here on our Zoom meetings or our town halls, but she is here in an official capacity today as a PC Project Board of Trustee member. And I've asked her to help me out today. So she's going to help me keep organized and straight as we move along. And I know we just had a town hall meeting last month where not last month, last August, where I literally talked for not an hour nonstop. And if you want to see that, I might refer to that later in this day. But it tells you everything you possibly want to know about PC Project and what we're up to right now. And not a ton has changed in 3 months. I mean, well, a lot of little things have changed, but overall the message is the same. But I just thought we get so many questions all the time that it would be so nice to just have a meeting for you guys where you can just ask and answer questions. We've had so many submitted and we'll just kind of get going. I wanted to just remind all of you that just to stay informed at any point, always check the news and events section of the website. We try to keep that up pretty regularly. You can also explore the whole website for information. There's a lot of tips and tools and tricks on the website. If you just start exploring and going down a few rabbit holes on our website, you'll find there's a lot of really good material. The other thing I would recommend is that you always read your emails from us or newsletters. And clearly you did that if you are on here today. You can also follow us on social media. We're on Instagram, Facebook, LinkedIn, and X now. That's all. Well, oh, we're starting a little bit on TikTok, but that hasn't taken off. But we're on there, but not anything nearly as comprehensive as what's on the website. And of course, if you want to know some stuff, you can go to the website or excuse me, yeah, go to the website and look for one of our past events. It's the town hall. And one of our board members, John Dew, gave us a little AI of it so you can actually see what's on there. So with that, I wanted to just, before we get started, just remind everybody that PC is a genetic PPK. And what that is PPK stands for Palmer-Plantar epidermal differentiation disorder. And we've always been an EDD, as you want to call it, but we are officially reclassified as a Palmer plantar. And I've got on the right side of the screen just a little snippet from from the publication that reclassified all of these genes as Palmer plantar epidermal differentiation disorders. And here's another shot from it. I wanted to just tell you really quick for reference, what is PK? It basically stands for palmar plantar keratoderma. So palm refers to the palms of your hands. So a lot of us have thick skin on the palms of our hands. Plantar refers to the soles of your feet. I'm just following along. You probably saw this on social media. And keratoderma means the thickening of the outer layer of the skin. And so basically, if you have palmar plantar keratoderma, you have thickened skin on the palms and soles of your feet. And there's a lot of people, a lot of different types of PPKs. Some are born with it, like us, with PC and other PPKs, and others get it later in life. But at PC Project, we focus on genetic conditions with PPK, including the PC keratins that a lot of people on this call are familiar with. But we're also getting more and more people in our registry that have just other, I shouldn't say just other PPKs, and you can see a bunch of them. I didn't do any Palmer PPKs, but I just did these and just did feet. But just wanted to show you how similar they are to us. So just know we're all part of that PPK group. If you want to look on the website, Holly has some amazing charts. One is this data chart that shows all of the PC genes. You can click on them. This is just a screenshot, but you can find your own mutation. In fact, Roseanne and I looked up hers. We scrolled along all the K6As and found hers. And it's very important to us to know those. The same time, we're gathering more and more other PPKs in our registry, and there's a chart on our website for them too. And again, if you are on this call and you have PPK that is not one of the PC genes, that's okay. You're in our group, and we're accounting for you and your data. and we care about you very much. And and the reason I wanted to give this introduction is because some of the questions um, in our discussion are going to be about this. Wanted to just let you know in the patient registry right now, there are over 3,006, well, 3,006 as of last night, patients in the registry. 1,748 patients are fully enrolled, which means we processed them, we've genetically tested them in some way. 1,292 have a mutation, a PC mutation. 171 has a mutation in another PPK gene that's a lot like us. 163 had no evidence to test. So, if you join the registry, we evaluate everything. And if we don't think we can pick a variant on our panel, we can't test. But 123 were also tested, but there wasn't a mutation found. So just wanted to point that out, but there's a lot of people in our registry in different processes, different areas of the registry, and we care for them all. But that's what's happening, and that's why we have other PPKs, and we are a PPK as well. So just so you know, every year we have a symposium for mostly PC. And this year we're going to combine with all the epidermal differentiation disorders in Chicago. And you notice Pierre is one of the organizers. Actually, we are too. And so we're getting ready for that. And that's an important thing where we get all of the people together who are doing any kind of work in our disease space because we care about you all. I know I'm going fast, but I want to get to the questions. And why do we care about getting together with all the researchers? If you're following us on social media or the newsletters, you probably see we kind of have been really heavy on the meetings lately, but it's so important that we have scientific meetings where researchers and physicians can present their findings, discuss them, they can collaborate, and this energizes the existing scientists, and we try to win their hearts, to tell you the truth. And the reason why is if we don't get their attention and get them to think about us, nobody will. It's our job as PC Project to get that to happen. So that's what we're doing. One other just quick announcement I wanted to let you know that because we've been asked and we just haven't got it down yet is we are set to have our patient support meeting in 2026 in Europe. You probably know we go back and forth. We're down to London or Paris. So if you would like to vote, put it in the chat or email me and let us know. Do you want it in London, either July or September, or do you want Paris, either July or September? So please feel free to light up the chat and vote because we're not there yet, but we're getting closer. Okay, I know, Melanie, should have been Germany, right? Okay, but we're thinking about a 1 day there, so we'll be in touch. I just wanted to say last thing too is our first peer-to-peer fundraising campaign brought in over $53,000. And just so you know, this wasn't a campaign where we asked you necessarily to donate. We asked you to ask your friends. And I just want to tell everybody, thank you so much. This was the highest campaign we have ever had. None of the stuff we do is free. So just wanted to give a shout out. Thank you so much for participating, for those who were able to. So want to let you know that the campaign is in full force. You probably noticed that already. I see Amanda, one of our scientists, is on the call, and she very nicely submitted her picture for me. I asked her if she'd do it, and she was so nice. So that is a real PC scientist right there, just so you know. And of course, we've got cute Olivia. With that, I want to just go to what you guys are already here for, and that is our town hall Q&A. And with that, I've got all the pictures up here. I wanted to ask Roseanne, because I talk so much, if she'll go ahead and introduce our esteemed experts.
Thank you, Janice. Can everybody hear me okay?
Yes.
Okay, terrific. So it's my honor and pleasure to introduce our esteemed panel of scientists, researchers, and doctors who have really all been with us since the inception of PC Project. So if my math is right, that's like 100 years of experience, all dedicated to PC Project. So thank you so very much. It's my honor to introduce Dr. Pierre Colombe, who's a world-renowned scientist who studies keratins, the proteins that help give strength to our skin. And he's been with us for well over 20 years. And as you saw Amanda's picture, Amanda is part of Pierre's laboratory. So we're so happy to have you here. And please feel free to jump in and offer anything else you'd like to tell us about yourself. We have Professor Adele O'Toole. She's a dermatologist and researcher who specializes in genetic skin diseases, including PC and other PPKs. She's with the Queen Mary University of London, and she has led a number of clinical trials, both for PC here and in the UK. And of course, we have our amazing Dr. David Hansen, who's a longtime dermatologist and one of PC Project's closest clinical partners with the University of Utah. He serves on PC Project's medical and scientific advisory board, our genetics team, and the International PC Research Registry. And who would we be without our wonderful Dr. Robin Hickerson? She is a co-founder of 10 Bio Ltd, a company that develops advanced human skin models to test and improve new treatment for skin disorders. She also creates medicines for genetic skin conditions, both in university labs and in the industry. Robin has been with us way back to our Irwin McLean days. So thank you so much, Robin, for all that you do. And last but not least is Dr. Michael Caterina. He is also a co-founder with Robin and a leading expert on how and why our bodies feel pain, focusing on understanding what causes pain in hereditary skin conditions, including painful PPKs. He is professor of neurosurgery and director of neurosurgery pain research with Johns Hopkins School of Medicine. So without further ado, let me turn it back over to Janice and our esteemed colleagues to share with us today.
Thank you. Wanted to ask all of you experts, did we get it right, or is there anything we should correct or know about you guys?
Sounds great.
I'll just point out, as much as I'd like to claim credit for the very exciting stuff that Robin is doing, I have not been a contributor to that effort, although I look forward to seeing all the things that have emerged from that. But I don't want to take credit where it's not due.
My apologies. Thank you.
No, it's good. I think she meant you were just part of us, maybe. I don't know. Either way, the beautiful thing about all these experts is that they've stuck with us all of these years, and we just love them so much and really appreciate that they're taking time on a Saturday. They're just doing this for free. So hope everybody just can give them a big thank you for that. With that, we are going to move to the questions. And I am just going to see why my thing's frozen. I swear it happens every single time. I think it's all the bandwidth here. Okay. There we go. Okay, guys, I'm just going to tell you right now, we have 8 of these slides. So with that, let's just go. First of all, and this might be for our doctors, how can I better explain PC symptoms, especially pain, to doctors who don't understand diseases or who tend to dismiss symptoms? In fact, this is probably, I'm just going to read 3 of them because they all might be the same. I tried to combine them. As an autistic woman who struggles to describe pain and location, what are some strategies to advocate for myself and get appropriate medical care? Again, how should I tailor communication about PC when speaking with different kinds of doctors? In other words, our physicians, help us know, how in the world do we talk to doctors when it is so hard, when not everybody can go to London or to Salt Lake City to see Adele and Dave Hansen? So Dave and Adele, do you want to take that?
Yeah, I'm happy to start. So I think in terms of explaining PC symptoms, especially pain, to doctors who don't understand rare disease, some information from PC Project would be helpful. So for example, the information leaflet for medical professionals or information from the website. Also, I think in terms of describing pain, the severity of the pain, you could say things like it's just as severe as the pain of, severe arthritis, that's been shown, etc. In terms of the autistic lady, I would say probably bringing someone with her to support her and to, clarify any points, if there's, any confusion with the doctor, I think that would be helpful. I think also having PC Project advocate for her possibly would be a possibility as well. And I think also, so doctors, I don't know about it in America, but in the UK, doctors are quite task oriented. You come with a problem and they want to solve one problem at a time. They don't want to solve multiple problems. So I think it's good to focus on the biggest problem first, and then move downwards, in a step-like fashion. So for example, if you've got a cyst that bothers you occasionally, but the main thing that bothers you is the pain in your feet, then you need to discuss the pain in your feet. Or if you've got an infection on your foot, you need to get straight in there and talk about the infection on your foot. So that's just some points, I guess. Dave might have some more. He's older and wiser than me. He might have some more ideas.
Older maybe, but not wiser.
Probably sees a lot more patients as well.
I agree with what Adele said. I think the most helpful thing is to provide information to a physician, and PC Project has created brochures and so forth that are designed for medical professionals to try and explain PC and the PC pain. The other aspect, I tell patients, and I agree with Adele, you concentrate on the thing that's most important first. Because as she mentioned, most people said, tell me why you're here, I'll deal with that first, and if I have time to deal with everything else. But they say, I have pain in my feet, and it's like walking on cut glass. So every time I take a step, I have pain in my feet. And to give them sort of a visual of what it is to walk with PC. The other things that are helpful sometimes is that we can support the patient or support the individual with information for the physicians. And I mentioned the brochures, but even contacting PC or the website gives information about the disease. So if they're interested at all, there's good information available to be helpful in advocating for the individual with PC.
Perfect.
I would also add that the doctors who work with PC Project on the advisory board are, more than happy to link to a specific dermatologist for discussion or some other physician if that's necessary. It may not be if you show the brochure and do everything else, but if it was needed, we can do that.
Which is amazingly amazing. Thank
And it
you.
has happened before, we have done that.
It sure has. These guys are great. One thing too is we've also noticed that if your doctor doesn't know about PC initially, that's okay. As long as the doctor is willing to listen to you, to learn, you show up with a PC brochure, that's okay. We can educate a whole bunch of doctors that way. I wanted to ask you guys about this last question in this area. For a person whose main issue is pain rather than infections, is it helpful to see a pain specialist instead of or in addition to a dermatologist?
I think definitely yes.
Okay.
I think pain specialists quite often have access to other pain meds that a dermatologist might not have access to. Yeah, I think it is helpful for people who have very, very severe pain, definitely.
Excellent. Thank you. Let's go on. I'm moving us fast. Infants and children. This could be really about the same as the above, but how can parents best care for a baby diagnosed with PC, especially in areas where doctors are unfamiliar with the condition? How can I help care for him and advocate for his medical care? Is that kind of the same?
The newborns have some specific concerns, particularly with swallowing, with breathing, with the changes in the oral cavity. And sometimes it helps to have PC Project advocate for them to help physicians understand what's happening before they do surgical things in the throat that can be damaging to the individual. So I think particularly in newborns, it's very important to physician to communicate with PC physicians to know how to best manage those things.
Right. And the good news is for most of those babies that have those issues, they're usually K6As, which show up with nails at birth. So if you have a baby and you're not sure if it has PC, it will mostly likely not be having those issues that we're talking about unless they have that K6A mutation. So, okay, my baby gets nail infections every few weeks. Is that normal? And what can I do to prevent them?
I think that's a tricky one. It is normal. It does happen, and in babies with PC. I think it may be, I mean, I think it's poorly understood, but it may be because the nail barrier isn't as well formed, earlier in life as an infant as it is when you get older, because it does seem to improve as PCK6A patients in particular get older. So for treatment, sometimes we use things like topical antibiotics. Sometimes if there's actually a collection of pus there, it might need to be drained, which a doctor can do very easily, and some parents actually know how to do this. Sometimes it might need oral antibiotics.
Thank you. And how can access to mobility aids and walking supports be improved for all PC patients, especially children?
I think it depends on the part of the world you're in. Certainly in the UK, what would happen is I would probably refer to podiatry for things like possibly special insoles, and then to occupational therapy if there were issues with walking, for walking supports or mobility aids. So for example, if somebody was very, very severe and needed a wheelchair.
Thank you.
I would
Okay.
agree that usually the medical system, and I would do pediatricians for kids are often quite helpful with that. A podiatrist may also be helpful, and you try and deal with it with the least invasive type of medical support. So wheelchairs would be a last resort, for instance, but inserts, types of shoes, and so forth, education in those areas are also very helpful for kids.
Perfect. Thank you. And once again, come armed with a PC brochure.
Right.
Okay. Just so you know, we're going to pain. Everything's kind of under pain. Then we're going to go to research, and then we're going to go for a whole lot of just other doctor questions. But I think, and Mike, just know you can come in here anytime you want as well. And Pierre and Robin, all of you, pain and pain management. So what is the root cause of PC and the skin thickening? And let's just start right there. Why does it hurt? And I guess we could say PPK pain as well.
I'm going to start off with a deflection and say that everything that we're learning so far suggests that the PC pain starts with the PPK itself. In other words, that it is the consequence of what's going on in the skin. So perhaps the experts who work with the root cause of the skin thickening might be more appropriate to address this question first, and I'd be happy to follow up with what I think is going on at the level of the nerves.
I mean, the current idea is that the keratins that form the outside part of the skin are poorly formed because of the mutation, and so they don't fit together well, and they produce a very fragile skin that in skin cells causes breakdown or blistering, and that results in inflammation. The inflammation then creates thickening because the skin tries to protect itself by callus formation, and as a side benefit or side problem with that, it also produces pain. So again, it goes back to the keratins that are not properly formed because of mutation.
I mean, I guess a further point is that in patients with PC who have calluses, and if it's severe, they might get these neurovascular strictures, which are these little blood vessels in the callus. And we think that there's a blood vessel and a nerve there. So it may be that the cells in PC skin secrete various inflammatory factors, so tiny little proteins that make the blood vessels and nerves come into the callus.
Right.
And I'll add to that once these things happen within the skin, that changes the whole behavior of the nerve cells that are providing sensation to the skin. So it's not just a moment-to-moment stimulation of the skin that's leading to the pain, but the nerve cells themselves change in their characteristics and in their responses to stimulation. And so when you look at a molecular level at nerve cells that are providing sensation to skin in animal models of painful PPK, what you find is that those nerve cells are expressing very different proteins and very different molecules than the nerve cells that are providing sensation to other parts of the body. So there is an enduring effect of the skin inflammation and the neurovascular structures that Drs. Hansen and O'Toole described, excuse me, that for some period of time makes the nerve cells fundamentally different. And so the other feature of that is that although some of those changes in the nerve cells at a molecular level are similar to what you would see in other inflammatory pain conditions, it's becoming apparent that some of them are really characteristic of painful PPKs, and might provide us with a better opportunity to understand why the pain is what it is in patients experiencing PPK.
Thank you. Boy, I could talk to Mike all day about some of this stuff. That's great. Thank you. Just so you know, for our experts, we had a ton of questions that probably fell right in this category.
Hmm.
So you probably answered 10 people. Is there anything new you've learned about why PC pain happens? Well, I think we've got that. And then what might help manage it? Maybe that's the key right there. Any suggestions on how to manage it? And we're going to get into some things underneath, but just overall, what would you suggest?
So I mean, I think there's obvious things like, pacing yourself. So everybody knows, after I walk a certain amount, I get pain. And that may depend on your mood and how you feel that day and how you slept the night before and multiple other factors. So I think pacing yourself is important. I think that a lot of people do require pain relief of some type, and some people take non-steroidal anti-inflammatory drugs like ibuprofen, which is anti-inflammatory, and I think that does help some people. But obviously, if you take it long term, it can cause problems with your kidneys and also cause indigestion, especially if you take a high dose. Some people take things like acetaminophen or paracetamol. I would think, in my experience, maybe that doesn't work quite as well, but it does work for some people. And then you sort of move on to stronger painkillers like codeine related painkillers. So things like cocodamol, tramadol. I'm not sure what the equivalent is in the US. And then there are lots of drugs for neuropathic pain, some of which have been tried in PC patients. So examples are amitriptyline, gabapentin, pregabalin. The next question is on duloxetine. So duloxetine is an antidepressant, but it's actually also a treatment for diabetic neuropathy, which can cause pain. So as well as having an effect on the brain, it also has an effect on the nerves coming from the spinal cord. So in that way, it can help pain. So I think your doctor's suggestion of duloxetine actually may not be so bad. Then there are some topical things. So some people use a capsaicin patch. They have that put on every now and again, every couple of months. That can work for some people. Some people have Botox injections. Some people use topical lignocaine. I have known of a patient who had intravenous infusions of lignocaine. I think that's about it. Some people have taken statins.
Yeah, and you can see at the very last one, have statin type medications help reduce calluses or pain in PC patients?
Yeah, there have been some case reports. There was one particularly spectacular one of rosuvastatin in a child. Seemed to work very, very well to reduce callus and reduce pain. But then there are others, I think, who have taken a statin or who may coincidentally be on a statin, because it's very common for people over the age of 55 probably to be on a statin, who haven't really noticed any big change in their pain. So I think the jury is out there. It's not clear.
We did a small trial a number of years ago with the statins and didn't see much success. But there's individual case reports again that suggest there might be a relationship. I always look at the PC pain as neuropathic and neurogenic pain. To me, this is pain that would be similar to what we call post-herpetic neuralgia, which is the pain that comes on after having shingles. I'm interested in Michael's confidence, because he's the one that's really the expert in this. But the medications that Adele mentioned, like the pregabalin or the gabapentin or capsaicin, try and block that type of pain for neuropathy and for shingles type of pain. And I think they could be quite helpful, but we don't have a lot of experience with that. So, Michael, your thoughts on neuropathic pain?
Sure, thank you for that. And so I'm not myself a pain clinician, but I interact with a lot of them and collaborate with them on thinking about understanding pain in general and better ways to treat it. And what I will say about neuropathic pain is that there is an emerging recognition among those clinicians who do treat neuropathic pain, whether it's due to post-herpetic shingles type pain or diabetic neuropathic pain, other neuropathic pain conditions, that sometimes it's less important what condition is triggering the pain than to understand the precise symptoms that a patient has. So, for example, patients for whom a burning pain sensation is a major part of what they experience versus patients who sense numbness, or patients who get a lot of tingling and sudden sharp pains. Those features of the pain are useful for physicians, particularly pain medicine physicians, to take an educated guess as to what neuropathic pain medications might be most helpful for a particular patient. And so, coming back to one of the questions from earlier, I would say that if you do end up seeing a pain physician, that the more precisely you can describe the quality of the pain, the nature of that pain that you experience, the better chance that they'll have of making a better first guesses as to which medications might be helpful.
That's really great. I'd be curious if you guys wanted to put in the chat, patients, what does your pain feel like? Is it burning? Is it stinging? Is it, you know what I mean? Put some of your thoughts. I'd be curious to know. Great ideas. I'm just seeing if we got it all. One thing that's an interesting, I just would make a note that some of our patients who have been on some of the kind of the opioid type drugs, um, sometimes tend to have, it's really interesting, this comment, I worry that I should end up with my feet worse. One of the worst feet we ever saw was a guy that had a morphine addiction. And because he was masking the pain so badly, that he just caused a lot of trauma to his PC feet. So it was kind of a catch. He was able to walk, but the physical symptoms were a mess because it's kind of like not feeling the stove that you touch. So I thought that was a really interesting thing. So, and I just always want to be cautious on, anything that's addictive, but also at the same time, we know you're working with pain, and we're dealing with pain all the time. So it's a tricky balance to get it managed in a good way. I'm going to just skip this one at the top. I'm just going to go past it. I think we all know the most important pain related symptoms that should be prioritized is whatever is causing us pain. So clearly for PC Project, we focus a lot on the pain of the PPK, but we also are very concerned and actually have some research going on. We'll probably get to that soon too, for the pain of cyst. Cyst is a big issue for some of our patients, a lot of our patients actually. So we're going to have just a little more in pain. As a high school athlete who relies on ibuprofen to keep playing sports, what safer long-term options exist for managing pain? Oh, I guess we kind of did this. If painkillers help me walk more, is there a risk that I'll overdo it and worsen my feet? Anybody want to just talk to the athlete here? Are there any, or if we answer that, are there any safer long-term options?
The quick answer is probably no. No, narcotic type of things are more long-term options, but they have lots of problems with them. And so the ibuprofen is in my mind is a go-to medication.
Mm.
But what I try and encourage individuals to do is to take it before the activity, but then not take it the rest of the time or do it. And so if for instance, you have a match or a game twice a week, you would take it twice a week, but not in between. And again, dose and duration are the things that you have to be aware of because of the kidneys and the gastric or the stomach effects of the ibuprofen. So it's a effective, inexpensive medication for control pain, but it's not a great long-term daily way of managing it. Being careful about the number of steps you take and taking time off during the day to rest your feet may be also a part of trying to manage that pain, along with inserts and things you do with your feet to try to minimize trauma.
Yeah, I wish we could say this is the answer. That's excellent. One question I have for you guys is I once heard from a doctor that if I took food with ibuprofen, that would lessen the impact on the stomach. Like some of these people that have permanent GI problems because they've taken so much ibuprofen over the years, would taking food help mitigate or lessen that impact?
I'd usually encourage them to take it with food because I think it lessens the acidic effect of the medication on the gastric lining of your stomach.
Okay. Great. Okay, let's go to some specifics. Could a painful, bony feeling callus or sharp stabbing pain in the big toe be something bone related rather than just callus? It's always hard to know what's PC and what's something else. Any thoughts, doctors?
I think if there's a question that it's bony, probably it might be reasonable to have an X-ray. You know, if you can feel something, which is definitely really, really hard, just to make sure that you don't have some sort of spur or something like that sticking out, like a little bit of bone sticking out.
Okay, perfect. And this is a totally different person. How should I manage a heel spur with callus buildup even when using orthotics?
Again, X-ray with some type of intervention from a orthopedic surgeon or a podiatrist who needs to look at that where that spur is, and is there a solution, or can you again do something to prevent the pressure over that spur that causes the callus?
Thank
And,
you.
and spurs are permanent, so you would have to have surgery to take it away. But sometimes doing things like stretching the area or, you know, special orthotics, if the orthotics person is aware of the spur, can help.
Thank you. Okay, I hope we all know the answer to this. Could sharp pain near the jaw, ears triggered by acidic or sweet drinks be related to PC?
This is a condition that seems to show up in young patients more typically, and it's called first bite syndrome. When you go out to eat something, your salivary glands are activated, and somehow those nerves are connected with PC, and you'll get a sharp pain before you even take that first bite. And so it's something that's certainly seen in individuals with PC. And it's my understanding that it tends to get better with age, so it gets better as they get older.
Okay. And we know it's a lot of kids. In fact, if you want, put it in the chat if you've had that ear pain that comes with taking a drink first or eating first. Be curious again on that. Okay, future of pain treatment, and then we'll go on to research because that's kind of just going to segue us right in. What progress is being made toward better pain relief for PC? Going to just add them both. What is on the horizon for new pain treatments or pain research?
So, I mean, I can say a few things, but I'm sure Michael knows a lot more. But A company called Camari is developing a TRPV3 antagonist, which will be used orally by mouth. And they're trying it initially in Olmsted syndrome, which is caused by mutations in the actual gene TRPV3, which activate TRPV3. So it makes complete sense to try and inhibit TRPV3. But TRPV3 is also upregulated in Pachyonychia congenita. So it's likely that a TRPV3 inhibitor might help. There are also some companies who have TRPV1 inhibitors, and there's also some interest in cannabis-like drugs, so drugs that work on the cannabinoid receptors and their use in management of pain. I haven't heard anything about any company who has those been interested, particularly in PC, but yeah.
Okay, we'll get to some clinical trials too in a minute. I was going to say, Mike, do you have any thoughts on just progress on pain research?
Yeah, so I think you can look at this in two ways. One is one can prevent or diminish the pain associated with painful PPKs by treating the painful PPKs themselves. In other words, rather than focusing on pain as a symptom, focus on the underlying cause. And I think that some of these therapies that we've heard about, like TRPV3 antagonists and so forth, if they turn out to be effective, it might be because they are interfering with the callus formation in the skin. And ultimately, that could end, those kinds of approaches that target the formation of the calluses could end up being the most powerful means of alleviating pain. But in the meantime, until one knows how to block those processes, then the kinds of therapies that we've heard about that are associated with treating pain in general are things that physicians could explore with the patients. And the field of pain is a dynamic one, although there haven't been a lot of new pain medications to emerge in recent years. There are some that are in clinical trials or in the drug development pipeline. And again, because some features of pain are shared across painful conditions, regardless of whether it is a hereditary painful skin condition or not, then it might turn out that some of those new drugs that are evolving could turn out to be useful for treating pain in patients who are living with PPKs.
Thank you. Okay, and this is the part we had a ton of questions also, not just, I'd say pain and research were our #1 questions. So we tried to put them all together. And here's the first one. Are there any animal models for studying PC? And I hope Peter's getting revved up over here. And Mike, you might too. I don't know.
Yeah, let me let me say a few things about this. So the answer to this is yes. We have an animal model that we've been working with for several years that's focused on the K16 gene, that in which the K16 null mice that do not have a functional copy of either of the K16 genes, are developing foot pad skin lesions that are as best a mimic of PPK as you can find in a mouse. So that mouse we've been studying for years. We've learned a lot from the pathophysiology of PPK, from the study of these mice. And now we have a second generation model in which we have a PC causing mutation in the human. And again, we focus on the K16 gene because we wanted to continue to be able to use the K16 null mouse as a reference. So that new mouse model that we have with the PC causing mutation does develop foot pad skin lesions that are very, very similar to PC again. So there are animal models, but it is very slow to develop them and to vet them as being a good mimic for PC. And then Once you have a sense that it's an appropriate model, and you know the limitations and the strengths of the model, then you can engage colleagues to sort of study select aspects of PC. For instance, my lab and Mike's lab, Mike Caterina's lab, have been collaborating for several years because he's a pain expert. So we can ask about, how do you gauge the experience of pain in a mouse? It's a challenge to do that, but there's ways to do that. But again, you can't have a conversation with a mouse, so it's quite involved to probe the molecular readouts that you need to probe to really know that you're dealing with pain in a way that's relevant to a condition like PC. So I will say on the general topic of animal models, there's not many because it's a very challenging endeavor because in part because PC is immensely complex as a condition. But they are existing, and we're building new generations of models. And so long as there are researchers interested in PC, and so long as there are funds to support these experiments, we can anticipate that there are going to be additional models. So I'll leave it at that for the time being.
Perfect, thank you. And maybe, I don't know if Robin's in a place to answer. Robin does work without models, but I know she's in the lab right now. Oh, she just unmuted. Do you want to talk about that at all, Robin?
Sure. So at 10Bio, we work with we actually work with abdominal skin from abdominoplasties. So it's not necessarily foot skin and it's not necessarily skin with disorders, but a lot of the proposed therapeutics for PC have to do with specific pathways. And so we can look at whether or not a specific drug will interact with the pathway or interact with the skin in a way that might reduce PC symptoms, even though it's not PC skin.
Perfect, thank you. Robin is busy in the lab today. That's why her camera's not on, probably because her hands are full of doing experiments. But she's right here with us, which is great. Thank you. And that's all important. Robin, she mentioned pathways, and maybe someone could explain. We talk about pathways, like we say we share a pathway with, for example, the Olmsted patients, or maybe there's other PPKs that we share pathways with. Could one of you experts tell us what that means when we say we have a pathway that's similar?
Well, let me take a crack at this. First, before I answer the question directly about pathways, let me say that the keratins that are altered, and these alterations being causative for PC, these keratins are specialized for response to stress. That is why they are so prominently expressed, for instance, in the palms and the soles of our skin, because that's where, from a mechanical perspective and other forms of stress coming to us from the environment, these are, regions of the body that experience the highest level of stress. But the stress responsive property of these keratins mean that basically, as a result of the PC process, there is a stress response program that gets rolled out in the tissue, and that includes the stress response keratins, which have very powerful properties, but also the mutated copy of the keratin gene builds up. So I look at PC lesions like PPK, and I think that this analogy could also apply to the nail dystrophy as well as to the cyst, as a sort of a self-fulfilling vicious circle that cannot be resolved, and it builds up, so that you make the lesion worse. In terms of pathways, pathways is like you could maybe it's a bad analogy, and the colleagues could tell me it's like languages that are spoken in the world, right? French, English, Chinese, and so forth. So a pathway is a way in it through which cells can respond to specific signals with specific responses. So depending on it's like I know French and I know English, and I can switch between them back and forth, but you need to have the knowledge to receive the signal, to process it, and then to respond to it. I mean, on the spot, that's my analogy to explain what is a pathway. And there's a lot of pathways that are involved in the making of something as complex as palmoplantar skin, or a nail, and the like. And there's also a lot of convergence in pathways that are specialized for the response to stress. It starts with making adjustments in response to environmental cues, but sometimes if these cues are too strong, or none of the right type, then you have a disarray type of situation. So there are a lot of signaling pathways that are involved in managing these responses. So that is why there's a lot of, PC starts with a defect in a particular keratin gene, but that gene is connected to an ecosystem of genes that have to do with normal management of what means to be palmoplantar skin, for instance, but also the management of response to stress. And that's where you get, so the bad news is that it makes it complicated. The good news is that because so many pathways are involved, there are multiple opportunities for intervention. We just have to understand what are the really important pathways, and how do they talk to one another, so that we can come in with interventions that may not be curative, but that might alleviate the symptoms. And I'll stop there.
Gosh, that was beautiful. I think it was really important that we all understand this, because we talk internally or in our community about treatments that target a certain pathway, whether it's going to, and I just wanted this group listening here to understand what that meant and why that's so important. Another thing is, early on in this town hall, I showed you all of the specific mutations and of PC PPKs, all of our PPKs, including us, and that we absolutely give you a genetic diagnosis so you can have, you can know what you've got. That is so important, but it's also super important to know what we're targeting, right? Mm-hmm. So you have to know. That's why genetic testing is such a big part of our budget, of our mission, everything, to give you a diagnosis, but also so we can have you ready, so you can know if a treatment is developed, if it will work for you, or potentially work for you, I guess I should say. Is that fair? Did I get that right, guys? Experts. Okay, so with that, this is kind of just wide, but what new insights are emerging about PC biologically? What new research development? So there's insights. What are we learning? What about research developments that are improving our overall understanding? What research is happening? I don't know if we want to throw in the current state of Olmsted syndrome research, because we share similar pathways. And what does development timeline look like? And is CRISPR a possibility? So I'm just going to throw that all out and let anybody here want to address anything. How's that?
Let me just start with the CRISPR question. So is CRISPR a possibility? Absolutely. CRISPR is a very powerful approach to go in a complex genome like the human genome and be very, very specific in the intervention that is being programmed. So we know what the mutations are. One complication is that so for each of our genes, we have 2 copies. And that includes the PC genes, of course, and only 1 copy needs to be altered in the right way to be causative for PC. So you really have to have an approach that targets the allele that bears the mutation, the bad copy, as opposed to any other genes, including the good copy of the gene. So there's that, but that we know how to do that. CRISPR makes it possible to do that. The 2 problems that we have that stand in the way to apply approaches like CRISPR for the cure or the treatment of PC is safety issues of safety, because you don't want to modify the genome in any way but the intended correction. And the other thing is delivery, and that's something that others might speak better to, notably Robin. It's very, very difficult to get these tools across the several layers of skin when the skin is specialized towards being a barrier. So delivery is a challenge that stands in the way of us applying powerful technologies like CRISPR to be effective in the treatment for PC. So I'll stop at that, because Olmsted, this is probably something that somebody else can pick up, and other aspects of this. But yes, CRISPR is a possibility, but there are some roadblocks to applying it to PC.
Anybody else want to take a stab at this?
Yeah, as a variation on that last discussion by Pierre, there's something called siRNAs, which means small inhibitory RNA, and this is a molecular agent that blocks the mutant. It's the RNA, which is the medicine, the chemical that goes from the nucleus to produce cell proliferation or cell manufacture, and it blocks that, so the mutant keratin is blocked by that. So that's something else that's been of interest to us for a number of years, but it's been very difficult to understand how to get that into the cells. And when you do that, is it effective in blocking the mutant keratin? So it's just something else in that same realm, dealing with the genetics, that could be helpful in the future.
Robin, do you want to add to this?
Sure. Thanks, Pierre. Thanks, Dave. Well, certainly there are advances that are being currently made in not only the delivery technologies, but also in the ability of the siRNAs to just be more specific and more potent. So I'm working with an academic in Georgia Tech his name is Mark Prausnitz. And there are a number of delivery methods that he's working on that would be applicable to delivering siRNAs and also CRISPR technology. And so there are a tremendous number of advances that are occurring or have occurred since, I guess I would say since PC Project made a big siRNA push, probably around 10 years ago, maybe 15 years ago. And so it's, I think siRNA is coming back, and I'm hoping that we'll be able to, direct some of that technology towards PC Project and be able to make some progress in that area.
Excellent. Thank you. We're excited about some of these possibilities ourselves. So this is great. Adele, because we have some K17s on and we have K6s as well, and K6Bs. Do you want to speak to what's happening with research with the cysts?
Yeah. So I have a PhD student who's a dermatologist who's taken 3 years out of program to do a PhD, who's looking at the genes that are expressed within the cysts. And we found some interesting things. Basically, the cyst seems to start in the epidermis, or the upper part of the skin, and then it seems to, drop down into the dermis, which is the sort of connective tissue part of the skin. And we've found genes that are altered in some pathways. So, for example, the mTOR pathway, which would be treatable with rapamycin, also known as sirolimus. And of course, many of you will know that there was a trial previously of topical rapamycin in PC. And there's also been Robin, who's on the call, was involved in a case report of 3 patients treated with oral rapamycin who actually did well. Their walking improved, the number of steps they took a day improved, their quality of life improved, but they all had to stop it because they had bad gastrointestinal symptoms. So yeah, I think it's just, I guess since then in dermatology, we know a lot more about that drug because it's used a lot in babies for vascular malformations. So there's a bit more intelligence about how to give the drug, what medicines you might give with the drug to make sure that it works better, etc. So that's a possibility.
Great. I'm dying at the time. It's gone fast. I just wanted to make a note here that you can go to our website if you want to see the current things of what's happening on the awarded grants. Um, go to just our website, awarded grants, and you can see a lot of the up-to-date research that's happening in the PC PPK world right now that PC Project has specifically funded. It's not telling everything that's going on, but there's a really good possibility. Another thing is, if you see the August town hall, I actually stole a bunch of Adele slides from another program and gave quite a thorough update on all the research that's happening in our disease space. So go back to that. It's on our website or it's on our YouTube channel, and you can see a lot more of the research that's happening. There is a lot of research. One thing, we talk about pathways. I want to move on, but we have given Alon Hovnanian, some of you here are from France, and might have even been some of the people that gave biopsies for this project. It's called proteomics, but basically he's finding a bunch of pathways and signatures, pathways, things like that. I'm probably not saying it right, but to find targetable places. Did I say that I tried to do it layman's speak, Pierre. Did I get that right?
Perfect.
Just know it's going on. It's really hard to sum up all of the stuff. I once made the comment to somebody. I said, I don't even really know how to sum up all the stuff that's going on behind the scenes. So you can look at what we're funding. There's other stuff that's happening. We go to these meetings and we collaborate with people. We talk with people, and there is stuff happening all the time that I simply don't know how to put in a newsletter. Or maybe I can't because of confidentiality reasons, but I want this group to know we're cooking. It's good. It's an exciting time. And this goes, we might have already, I just want to, can we be fast? Just do a couple minutes on this. Basically, what's happening on the clinical trial landscape? Let's do those first four. Adele, I might pick on you because you probably know the most. As far as the Kamari trial, that's the TRP3 inhibitor. That's what's happening next. Do you want to just give anything you know?
Yeah, so Kamari I put in the chat, they're having a trial of their oral TRPV3 inhibitor in Olmsted syndrome. It'll start probably in January 2026 for 3 months. But they are then planning afterwards to treat some patients with PC. There's also a company called Biomendix who has developed a topical drug, which is sort of a bit like sirolimus, but it works in a different way. It works on the mTOR pathway. And I think they're hoping to have trials for PC also. There's also a company called Solgel, which is based in Israel, who have topical erlotinib. And I think they may be planning some trials also, but I haven't really heard anything from them recently.
Yeah, they're kind of stalled on that one.
Is that it?
Yeah, they're stalled on that.
I think that's it, yeah, at the moment.
Yeah.
I've also applied for funding for a trial, a placebo-controlled trial of erlotinib in the UK for 34 patients. And Alon Hovnanian actually has obtained funding for a trial of 24 patients in France of erlotinib.
Yes, and we've got some funding request out in the United States as well for that same trial. It's an off-label drug that's showing some promising results for some patients, but until we really study it officially, we can't get it passed, we can't get it approved. So we're excited about that. So those are two different drugs. And I know there's another company called Biomendix, and they're also doing a sort of an mTOR pathway. See, we talk about these pathways. These are all things that target different pathways. and they're doing a drug for EBS. That's a K5, K14. So you can see they are also palmar-plantar epidermal differentiation disorders as well. And so we're seeing what happens with their trial, and we may be next after that. We'll see. So with that, just know it's neat to have the research going, but it's neat to have it when the research translates into drug development and therefore clinical trials. I wanted to ask just on this last one, coalition of companies working on individual cures will find, do you think they'll find benefits for other types of skin problems? For example, you're probably, again, Adele, I'm picking on you, or maybe Dave, if you know this, for Netherton syndrome. There's several things happening right now for Netherton syndrome. Will they find a benefit for something else?
So Azitra is quite interesting. So they basically are attaching an inhibitor to staph epidermidis. So staph epidermidis is a drug that grows on everybody's skin. So it's quite smart in that, you know, when you put a cream on with staph epidermidis, it will be attracted to the keratinocytes in the upper part of the skin. And I know they've been working on Netherton syndrome, and they've also been working on filaggrin, which causes, if you've got variants in filaggrin, you get ichthyosis vulgaris, which is basically dry skin on the arms and legs of varying severity. Some people can be more severe, but there are tons of people with mild ichthyosis vulgaris.
Okay. So it could be a
So
possibility.
I think we can always learn things from trials in other disorders, yes. But I think you have to think in terms of the disorders that are like PC. So I think we will learn from trials, for example, in Olmsted. We will learn from trials, for example, in punctate PPK, because that too has epidermal growth factor receptor as one of the predominant pathways.
Right. Anybody else want to talk about drug development or clinical trials?
No, I think, you know, I see there's a comment in the chat, but one of the best ways is to be in touch with the Pachyonychus congenita project. And so I would encourage the people to do that. And this is addresses a separate issue, but I just want to say that I really admire that you're so engaged about your condition, and we need for you to be engaged and to teach us, the researchers, the physicians, and people interested in caring in health and so forth. It's very important that you stay involved and that you be vocal, because that's a wonderful, then it creates partnerships, and partnerships that are very powerful. And the PC project is an example of a highly powerful partnership. So, and that's because of you. So keep coming at us, because it inspires us and it guides us, and it's very important. Thank you.
Thank you. Okay,
Can I add to that by saying that I was at a meeting last night giving a talk about the new classification of EDDs.
okay.
And the meeting was run by a company called Almirall, who are developing new treatments for eczema and psoriasis. And they're a little bit interested in the rare disease space. But we got into a conversation where they were saying how hard it was to divert money into rare diseases. You know, that it was all the big bucks, eczema and psoriasis. So I think the patients lobbying for change in that area is important as well.
Right. I think too, that's
Janice,
why. Oh, go ahead.
Janice, just that on that topic, there's a question in the chat if we've seen any impact on PC research as a result of the cuts to the federal health funding here in the United States. And Dr. Katerina had responded, so we may just want to ask him to weigh in on that, because I think it's important. Everybody probably has that same question.
Yeah, thank you so much for bringing that up. That it really is an important question. I think that what I would say is a lot of what we know now about PC, about other forms of PPK, and about the processes that one might target therapeutically to try to treat these symptoms and to alleviate the suffering of patients who are living with these conditions. a substantial fraction of it has come from federally funded research into just basic biology or into the kinds of animal models that Pierre had described. And we are at a very delicate time in the world right now where the support that provides the fuel for biomedical research across this field and many, many others, whether we're talking about cancer, heart disease, diabetes, that support at a federal level has been declining and is threatened in many ways. And this is, if we look at what's been accomplished in medicine over the years, this is really one of the causes for celebration in many diseases, that there have been advances in many diseases that have led to complete cures for diseases, that have led to treatments for symptoms. And if we're to build on the exciting opportunities that were described earlier related to things like new drugs or CRISPR and so forth, it's going to be important that fuel for progress in biomedical research continues to be provided, and that we revisit as a nation and as a world the priority that we want to place on the biomedical research enterprise. And so I think that question is particularly timely and particularly important.
Thank you. And that's why we as PC Project 2, we fund grants, because we can't get everything from the NIH or from, the European equivalents. And, because we're rare. So that's why I always say, if we don't do it, who else will? In fact, some of our thoughts is if we can give enough money to researchers to get enough data, then they can go and they can get bigger grants as well from these founding bodies that have, millions of dollars that we don't necessarily have. But I think by us giving out grants, PC Project, when there's such an uncertainty, especially right now, that it's just super helpful, and keeps us on the map and keeps things going, because we don't want things to stall. There is a lot happening, and so we're going to keep funding as much as we possibly can to be helpful as well.
I'll just amplify that and say that is of enormous importance, that every amount that goes towards this effort does make an impact. And it's not just large grants that can change the field of medicine, but the more modest sized grants as well make a significant impact.
Excellent. Thank you. Okay, last one, just super quick. Can someone answer this really fast? With the Palvella trial, somebody felt like the effects were still helping. Is that possible, or is it something totally unrelated? Were the effects supposed to be permanent? Does anybody know, Dave or Adele, who was involved with that trial?
I think very unlikely that it would be permanent. The turnover of PC calluses is about 4 months. So even allowing for, gradual removal by your body metabolism of what's there in your feet, I think it would definitely be gone by a year for sure.
Okay. Thank you.
5 years seems excessive. Would
Okay.
you agree with that, David?
Yes, that's it. Perfect. I think that the things we learned from the Palvella trial, first of all, we need to be able to better define an endpoint. What are we going to measure that shows progress in a clinical trial? And the second thing is that the improvement that some individuals got from the rapamycin thing, that blocks a pathway in the skin, and over time that's lost, and so that it's unlikely that would have lasted more than a year. Even that long would be a surprise. So
Okay.
we still need some good effort to follow up with that trial and with other ideas.
And with that, I wanted to just make a comment for all of you who get into clinical trials, and we've got some that are coming up that many of you might want to or be able to participate in next year if they're available, is to remember just what Adele said, that it takes time for those cells to turn over. And so that's why you notice the trials are like 3 or 4 months. It's a commitment. So shout out to all of you that have been in trials and that will continue to be in trials, because you have to wait long enough to make it work. So, okay, we've just got some basic questions. I think I might have already answered this at the very beginning. What is the best way to explain palmar-plantar keratoderma in relation to PC? Did we get that already? Does everybody know what that means? We're good. Are there other types of PPK that people with PC should know about? I think I answered that. Phil, show up. And Dave, you look like you're going to say
Well,
something.
and the website is a good resource for that.
Yes, yes. And what are we doing to support them? Okay, this was one. What are treatments for palmar-plantar keratoderma? What treatments or guidance exists for severe keratoderma fissures and incorrect past diagnoses? Should we just say, let's go to the website and you'll find stuff?
Yeah.
I'm
Yeah.
looking at the time. Is that bad? Well, let's just ask real quick. Are people with PC more prone to plantar warts?
No.
No. Okay, good. How can I prevent blisters under the calluses? Quit
Avoid
watching.
friction.
Yeah, I know some of these are so hard. I will tell you, when we've had so many new babies come to the registry lately in the last year, so many. And I think that's a testament to all of you, by the way, who have joined the registry, because now we have data about the registry from about PC, and it gets published. And so now when a baby is born, doctors are recognizing it better because there's publications out there about that. So we're getting diagnoses for babies sooner. But I will tell you, I'm sidetracked here, but it is so awful for me to have parents say, well, okay, now what? And I'm like, now you just got to live with it, and it's hard. Is there anything that can reduce or block the tiny nerve endings that become painful or make trimming difficult? Is there anything that can be done?
So I mean, I know some patients who use lignocaine gel before they trim. I also know some patients who use ice. They just put something cold on to sort of numb the area and then they go at it.
Yeah. It's hard because if you don't trim those nerve endings, or those blood vessels, nerve endings, whatever they are, they just grow up deeper, with the thicker the calluses get. So you don't want it to get that thick. You want to keep it down. It's kind of that balance of not too thick, not too thin. I think a lot of this stuff gets answered even in our PC chat. And again, any updates on medications or procedures to reduce or eliminate PC blisters? Basically, you just pop them as they come, right?
Yeah, I mean, I think that in the future, obviously, if there's an effective treatment for PC, that would hopefully take away the blisters. That's the hope, anyway.
Right, Dave, were you going to say anything?
No, I would agree with Adela. The other thing is that if there are activities that produce blistering, those are activities you avoid. Just sort of common sense. But friction and pressure are the factors that actually induce blistering in the skin. And so usually it's activities that will produce the blistering. And so being aware of that and trying to avoid those if possible, and it's not always possible. So you try and drain the blister to relieve the pressure.
Perfect, thank you. Oral symptoms, just one. What causes inflammation at the corners of the mouth and the white patches inside the mouth? And how can they be treated? So we got two different things. The little corners on the mouth, the little sores that grow, I think. What causes that, and how can that be treated, I guess? Maybe that would be the first question. It's that angular cheilitis, I think.
Angular cheilitis.
That's why we have a doctor in the house. Is there anything that can treat those? A lot of PCers get those, actually.
Sometimes I use things like mild topical steroid with antifungal or something like that. We've got a product in the UK called Dactocort, or Trimavate is a slightly stronger version, which we would use. It's important also to make sure that the person isn't iron or folate deficient, because that too can cause angular cheilitis.
Oh, okay.
Or, if you've got problems with your teeth or drooling or that sort of thing at night, that can also exacerbate angular cheilitis.
Okay, thank you. And the white patches on the inside of the mouth, how about this, just for sake of time? That's leukokeratosis, right? It's just the buildup of keratin in the mouth. And I don't know that anything can be treated. We just scrub it and brush it, right?
Yeah, I mean it happens because the PC keratins are expressed in the oral mucosa. So that's the wet skin basically inside the mouth and the tongue. And it occurs particularly on areas where there's friction. So at the jawline where your teeth come together, and
Mhm.
also on the tongue.
I'm sitting here in my own self go, oh, yeah. That's right. Okay. Just one of those fun things we deal with, but it's not harmful though, right? And it's white because it's wet, right?
Yeah, I mean, I think one of the issues is that sometimes dentists think it's leukoplakia,
Yeah,
which is precancerous, and they get all excited when they see it. So for PC patients to know that it's not harmful is important.
right.
It's also misdiagnosed as yeast quite often.
Yeah.
They use yeast medications, and it's really not an infection. It's a thickening of the outside, the keratin, as we talked about.
Right. Okay. Good job, guys. For all of you, we got a lot of questions on um, aging a little bit. And by the way, I'm loving the stuff that's coming up on the chat. So we will have a record of the chat. So I'm loving all of your tips and your thoughts. So keep it up. Keep the chat coming. Loving it. We're almost done, guys. I want to give you hope, unless you're dying here. But with cyst and follicular hyperkeratosis, acne-like lesions, is there any information on managing the follicular keratosis or PC related body cysts? And how can we stop the pimples or cysts that appear on the face as we get older? So I think we've got two things going on. We've got, the little bumps, the follicular hyperkeratosis that comes on the elbows, the legs, the waist, and then we've also got the cyst and that come on, and it's gonna, we get older, it's gonna go right into hormones and aging. We got a lot of questions on hormones and aging. So let's take the cyst and the FHK stuff first. Any comments on that?
So if the follicular keratoses are minor, so if they're not too massive, they may respond to things like topical amlactin, which contains an acid which can remove, well, not really remove, but flatten the keratoses. I will leave the cysts to David.
Cysts are difficult because they're difficult to prevent the cyst. It's managing the cyst, and basically you need a physician to help a little bit, either draining the cyst or injecting the cyst with an anti-inflammatory medication if they're quite red and painful. As you mentioned, with the follicular hyperkeratosis, there's a number of keratolytics of which amlactin is an example, or lachydrin. Salicylic acid or salicylates also are very effective with that, and can be compounded and used as a topical lotion or cream.
Okay. And I would say too, with some of the stuff, Adele didn't say it, but there are some things that are getting discovered about cysts that there might be some potential treatments that we are wait, how do I say this? I'm trying to say it carefully. Basically, I was in a meeting that had a potential treatment for these cysts. It's not, we don't know yet. They got more to explore, but the scientist that's working with Adele has has a possibility, and just want to give you guys hope, right, Adele?
Yes, of course, yeah.
Okay, so stay tuned. We're very well aware of you with cysts. We know how horrible those can be. Hormones and aging. So first of all, are you guys okay? Is everybody okay? We never really set a time, but I'm just dying at the time. But we're almost done. Does PC get worse with age, or does the condition mutate over time? I think we could ask the patients if they think it gets worse themselves, but but does it mutate over time?
I can I can I can jump in here. I'm not the probably not the best one on the panel to comment on this, but I think that probably this question is coming from the like the idea that viruses can mutate over time and become like less virulent or more. But that wouldn't be the case for PC.
Okay.
Janice, we do have a comment in chat that someone who is now 68 said that it is getting worse with age.
Okay. You know what? If anybody wants to put those things in, that's great. I mean, I'm looking at it too. It's so interesting how things change. And maybe that comes up with the next part. Can hormone treatments like estrogen or progesterone trigger PC flares or worsen symptoms? This is from a K6C. The feet were great, minimal pain, very manageable skin. I started taking estrogen and progesterone and not long after have had terrible flares like I haven't had in 20 years. Is there any correlation? I stopped the hormone replacement, hoping it helps. And with that, what do we do? What do we know about PC and hormonal changes generally? Anybody want to talk about that?
I think Pierre has done some work in that area.
Yeah, so I mean, we have evidence in the setting of our studies with animal models for PC, that is mice, that there is a sex bias in the way the disease evolves, and how it responds to experimental treatments. So I'm convinced there is a sex bias in PC, but that is something that has yet to be explored in a formal fashion. It does not surprise me that a patient would see a change in the course of disease in the setting of sex hormone interventions. I'll
Interesting.
stop there.
Oh, that's good. Any others? I guess we're yet to be continued.
Also, I guess progesterone is known to increase proliferation of the cells in the skin and also to increase production of sebum in the sebaceous glands. So that might cause, issues as well.
Right. I've heard some people, some women will talk about, during the time of their period maybe, or certain times of the month that their cyst might activate more. They might be worse or something like that. Again, it's all just stuff that we hear from patients, but we haven't done an official study about. Already, just, from these questions in my mind, I'm thinking, boy, we need some medical students to do more studies. I want to do one on babies and eating and all kinds of things and nail infections and then hormones and how that works. That's part, I guess, of having a natural history study, but it's just really interesting. So kind of a basic one real quick. Are there any correlations between PPK and hypermobility disorders such as Marfan syndrome?
I think hypermobility isn't all that rare in the general population. So you may find somebody with PC who coincidentally has hypermobility. But Marfan syndrome is a separate genetic disorder
Okay.
with no connection with PC.
Okay. I think we might have gotten to this already. What preventative steps can we take to avoid complications with our symptoms is basically, and what should patients watch for to detect problems early? Just any advice as, kids are growing up, is there anything that could be done? I mean, I guess not really, just live our best lives.
Yeah, I mean, I think things like not putting on weight probably is important. Because if you do get overweight, then I think that's going to put more pressure on your feet and cause more pain. So that's just one point.
Sure. And it's hard for those little kids as they get more weight bearing. you know, that some of the ones that the palmar plantar or the plantar keratoderma doesn't show up until later. So, okay. And fortunately, this is why, well, fortunately, this is why we're here, but unfortunately, you know, people say, oh, if I can just get good shoes or get socks, maybe it'll prevent those calluses from growing on my kids' feet. It just is going to come because they are going to get more weight bearing as they get older. It just happens. But that's why we're here, right? Oh my goodness, I thought this was the last one. Let's just see. Oops, let me just see if there's anything we just want to touch. I mostly want to be respectful of everybody's time. This might be an important one. Is there any guidance on managing chronic wounds or cracks that fail to heal? And I'm sure this is the plantar keratoderma. Well, it could be the palmar and the plantar. Is there any guidance on how to do that?
Usually managing those would be to thin the keratin, so to pairing like we talk about with PC, and then using an emollient, something that's quite heavy, a Vaseline type thing, Aquaphor, those are the US equivalents. Somebody makes some Flexitol, which is again a variation of that, to hydrate or to keep moisture in there. It helps to heal the cracks.
Okay. Thanks.
And
I'm not-
sometimes I prescribe a tape which contains steroid, and the patient sort of can seal the crack with the tape. That sometimes helps. But the first thing to try is what Dr. Hansen said.
And again, on our website, on the tips and tools area, there's a lot of good stuff on that as well. Not so much on the chronic wounds. That's a tough one. That one you go see your doctor about, I think, right? Just see if you can deal with that. Just some advice. We can put this on our website, even on the tips and tools. Flexitol 25% Heal Balm. Somebody had said it's really helped them. The thinner hard skin on my feet have disappeared. So just FYI, maybe potassium. I don't know what this is.
Permanganate.
Thank
Yeah,
you.
so potassium permanganate basically is used in the UK for you know, if you've got an area on your foot that's weeping and infected, for example, to dry up the weeping. The equivalent in the US is aluminium acetate, I think. Yeah,
It usually turns you purple.
yeah, it does.
So,
Well, no, actually, you're supposed to dilute it so it's pale pink.
I see. Okay.
If you haven't diluted it enough, it'll be purple.
So only if you have that issue would you even consider it then.
Yeah, exactly. It isn't for a treatment for PC per se.
Okay. So this is an interesting thing. How you can tell I do Chat GPT because they have all these titles. How are treatment options in clinical facilities evolving worldwide? Unless anybody has anything to say about that, I just say that we love it when we can get a representative in a different country to be kind of the head person for that country. For example, we have a doctor in Vietnam, and he sends all his patients to us, or he's kind of the guru for PC in that country. So we recognize that we don't speak a lot of languages, but we're trying to help people worldwide. My assistant speaks fluent Spanish, so that's really opened up a lot of Spanish doors for patients. We're helping a lot of people in South America, Spain, Central America as well. Anyway, we're trying. She's not on here right now, but we've got a doctor from Iran who follows everything we do and translate it for her patients in Iran. So we're doing our best. But if anybody wants to volunteer and help, that'd be great. I think this is for Adele. Besides Gosh, is anyone in the UK offering Botox injections for PC related sweating or pain? Any idea on that?
Yeah, so there is a derm surgeon at my hospital who does Botox injections for sweating and or pain, but he does it under local anesthetic, so the patient doesn't have a general anesthetic, whereas at Gosh, I think, is done under a general anesthetic.
Okay, we should get
Gosh
that.
is a pediatric hospital.
Yeah, do you want to speak at all for Botox at all? Just in general, your thoughts?
I mean, I think it does work for some patients. It seems to reduce the hyperkeratosis or callus and seems to reduce the pain. But it is medical resource intensive. So ideally you would have to have a nerve block, which is what they do in Israel, to reduce the pain. So that would require an anaesthetist as well as the derm surgeon or plastic surgeon or whoever injects the Botox. Our derm surgeon actually uses Intonox, which is sometimes used during labor for mums as pain relief. So you inhale it basically, and it helps the pain.
Okay. Thank
And
you.
that works for some patients, but not for everybody.
Right. Jury's
I
still
have-
out on Botox. Go ahead.
I have no
Dave.
personal experience in using Botox, but I know that we have reports of it working. The biggest frustration in my experience is that it's temporary. It lasts for a period of 3 to 4 or 5 months, and then you have to repeat that. So if you're looking for a long-term solution, it means 2 or 3 times a year undergoing the discomfort of injections into your feet.
Okay. Ellie, I see you in the chat. You know, it would be really helpful. Could you send me an email and tell me all about your experience, or even afterwards? I'm mostly being sensitive of the time, but you've caught my attention. I'd love to hear about it. We just don't have that many case reports about Botox. I just, we talk about the pros and the cons. We want to know why and let patients make a choice, on what they want to do. As far as disability and resources, it's going to depend on your country. It's going to depend on your state. Most of the time, we can give letters of support, and then you have to take those to your doctor and then get the disability depending on where you're at. Whether it's a handicap placard, whether it's accommodations to wait out of PE at school or physical education at school. There's a lot of different accommodations that our patients need, but just mostly know you can come to us. We can give you a letter of support that tells why PC. We make it sound really bad, and you can go and get those local supports. I just want to see.
Janice,
Oh yeah, go ahead.
I'm sorry to interrupt. There's just 2 questions on the chat. One is, can someone comment on mechanical debridement? Not
Sure.
sure exactly.
What the question is it just like how?
That is the question. If someone can comment on mechanical debridement.
Go for it, Dave or Gal.
I mean, I suppose the question is, what do they mean by mechanical debridement? Because debridement to me is fairly intensive, i.e. cut off the callus totally, as opposed to, just minorly paring down the callus so it's flatter than normal.
Right.
So I think a clarification on that would be helpful from Cameron.
There are instruments that are like a drill, but that have a sanding type of the top, and you could sand the bottom of your feet with the drill. There's a name for that instrument.
Oh yeah, so he said
Dremel.
Yeah, Dremel, thank you. And I suppose you could use that as an option in terms of that, being careful that you don't go too deep.
Yes. One of the things that I think is really, were you going to say something, Adele?
Yeah, so he has for further point in the chat, it is one of the treatment recommendations in textbooks. I think it's a posh way of saying paring down the callus basically, and whether you do that with a scalpel or a blade or a Dremel, or one of those cheese type things or pet egg, any of those options, whatever suits is fine. And it is the mainstay of treatment of PC actually at the moment, I would say, of PC callus.
Right.
And not too thick and not too thin, because if it's too thick, it's going to feel like you're walking on rocks. But if it's too thin, you can get in really bad trouble. At the bottom of a skin, I don't know who I'm talking to or what your reference is, but even on our patient group chat or on our tips and tricks on our website, I would say those are much better than your textbook. And you want to be careful, because it's not like beautiful baby skin underneath. It's yucky stuff. I don't know what it is. But it's if you trim way too thin, you're going to be in a whole lot of pain. And I think patients get that mistake. They go to a doctor, they go to a podiatrist or even a dermatologist that doesn't know what's happening. We see this time and time again, where they get excited. The doctor gets excited. They trim way too much and hurts the patient terribly. And then it takes weeks to recover from it. So lots of different tools. Again, I refer you to the website. And you know what? I'm going to this is it. We have one last question. I'm going to give it to Roseanne, is how can we, this is not it. I'm just going to say, how can we, somebody asked, how can we educate people about this? Because everyone knows about the other diseases, but not PC. And it goes back to what Pierre said earlier, is it's up to us. We're the ones, that's why we do the big campaigns. We have to share the word, because I mean, I used to hide. I used to lie through my teeth. I'm from Utah, and I always said I had a skiing accident or something exciting. But I realized if I don't talk about it, how will anybody know about it? How will we be able to raise funds? How will doctors know about it? How will researchers know about it? So I just want to say thank you to all of you that have talked about that, and who get the word out. We're the ones. How do we get the word about? We are the ones to do it. Last thing, somebody had asked, how can I become more involved with PC Project? And I am going to give this to Roseanne to answer this last question.
Thank you, Janice. I mean, the way that everyone can get more involved is I am imploring you to become advocates of PC Project. We have 16 countries that are represented today. As Janice said on her very early slide, I mean, over 3,000 people have reached out to PC Project, and we only have Janice and Holly. That's it, just 2 full-time people. So I'm just imploring everyone to be part of the advocacy team, to represent all of our countries. And I'll be happy to lead that endeavor and reinvigorate the team for 2026. Because as Janice said, it's our story. We have to use our voice, and we have to encourage others to take our journey with us, whether that's by fundraising, our doctors, our researchers, our scientists. So I'm just imploring you to get more involved, and I'll be happy to lead the endeavor. So reach out to me personally, reach out to PC Project, let them know of your interest, and I'll be back in touch with you.
Thank you so much, Roseanne. And you know what? We'll send something out in either an email or the newsletter, so that if somebody is interested in becoming a PC advocate, we can tell you about it. And Roseanne will tell you it's not too intense, to tell you the truth. It's just being able to represent PC in your corner of the world, or even, for big campaigns that we do. We actually have a patient as an advocate in Spain. She's not on today, but they're going to get together with all the Spain patients. We're really excited for them. So anyway, that's kind of what's happening with that. I think that is all. Oh, I always just have to say we're stronger together, right? And this is why we meet. And last thing, this is one of my favorite quotes in the whole world, and I often use it. Life is to be enjoyed, not just endured. And I think that's so important in the PC community, because we don't have a treatment yet, we don't have a cure yet, but we're here for each other. We're stronger together. But at the same time, we don't just want to say, oh, life is going to be bad until we get a cure or until we get an effective treatment. I just want to encourage you or invite you all to know that we're together. We're here for each other. Keep hope, keep with us, and we're going to be okay. We've got a great community. And with that, I'm going to stop sharing so I can just say hi and goodbye and just let everybody know thank you. I just want to do a very special thank you to our doctors, Pierre, Robin, Mike, Dave, Adele. Thank you for giving your time today. So appreciate you. And if you need anything, if you have any questions, you're welcome to stay after and talk, or just go have your fun Saturday. And just shout out again for the experts. Isn't this amazing that we have amazing experts on this call, that spent their time with us? So thank you. Can everybody just give them a thank you, and just keep up hope. We're here for you. We're a powerful group. We love you all. Thank you. Thank you.